Okay, now we're into week two. Before you start week two, review of anything last week that they haven't had some trouble with, any questions that they had. Now, week two, we go over a lumbar case. In that case, we'll go over it or we'll kind of go through components of it and what the expectations are throughout. So you look at the cases, a 63-year-old male, gradual onset of lower back pain, toes catching over the last 1 or 2 months. Go through it, go through mechanism of injury with them. Start by looking at things, as you see, aggravating factors. Say, standing, so are they more? Start thinking, get them thinking, what kind of sensitivities do they have? We talk about easing, sitting, leaning forward. So it seems like an extension sensitive patient. Go through it, go through nature of the condition, and we start looking at low back pain bilaterally. So we kind of say, if it's bilateral, is it more of a central problem? Keep an eye on it. He's concerned more about his toes dragging. So again, some red flags on both sides, some weakness. Look at meds. Just talk about low pressure. It's not bad. And some of the cholesterol meds. Start thinking if he's taking find out about the cholesterol meds themselves. If he's taking, talk about muscle issues that are related to it. As we move on, we start thinking of the MRI. And this is a good point to talk about degenerative changes with mild stenosis and remind them that 20% of the people, normals at 60, have stenosis on MRIs who are asymptomatic. We could also start looking at them and say that normals, 88% at age 60, have degenerative disc disease. So it's just something to be aware of, that just because they have that doesn't mean that's the problem. We move on, the outcomes component of it, so the person's moderate restrictions, moderate outcome score, Oswestry. Thoughts on this following the subjective exam. So when you're done with this, you want to go to severity. Severity again meaning how much is changing function. So we talk about moderate, meaning because the average is a 4 to 5 out of 10 range, and pain with function, but he's able to still do his function. So if it was severe, it means he just couldn't do what he needed, his functional part. Irritability, talk about moderate. He's still able to tolerate 30 minutes, can get all the way up to an hour and a half. So irritability is not high, which teaches you a little bit more. You can do your exam, can be a little more aggressive. The nature, which is the classification of the problem, we think of some type of nerve root involvement, some type of stenosis is what it looks like. And stage-wise, looks like more of a subacute, probably of a chronic issue, but it's the subacute part of a chronic issue. Looking at red flags, do we have any things we want to talk to them about? They do have bilateral weakness. We're going to ask more. There's no bowel and bladder, no numbness and tingling, just that the toe grabbing. We ask, make sure the student understands the cauda equina symptoms, etc. Go over that. As we go into the objective exam, this is the part where you get them to start to do the exam itself. Have them go through a normal exam, and here's the findings. Remind them dermatomes and where they are. We have here an L4 dermatome, L5 dermatome. DTRs, again, bilaterally is L3, L4, patellar tendon, Achilles is fine. Again, remind them of their myotomes, anterior tib, extensor hallucis longus, L4, L5, respectively. As we go through the exam, point out to them that the pain is produced through the range, lower back pain, lumbar extension. The key is that extension is quarter range, no pain, restricted, repeated motion results. There's no change in the symptoms. So it's not a directional preference towards extension, but with flexion, it produces a decrease in the lower back pain. When we look at the hips, the main point here is to realize there's some beginning of some arthritic changes in the hip, especially looking at hip internal rotation is the key component. Look at an OA hip. Capsular pattern has internal rotation, flexion, abduction as components of it. So just want to review there. Passive physiological, you're talking about similar findings, and also remind them of the ankle dorsiflexion is limited, which again we know could have an effect, and talk to them about what kind of effects other joints around it. If in your practice you do central PAs and lateral PAs, L4 and 5 cause the pain, and AP glide of the talocrural joint is restricted but not painful. So things. So we're going to go over and let them figure out, obviously, what the diagnosis most likely would be. Foot drop associated degenerative stenosis. From there, we'll go on. We'll talk, have them just give them some ideas of some type of flexion type exercises that would be appropriate. Practice-wise, we'll go through the components of it, teach them a little bit more about how ergonomically you look at a patient, how they go sit to stand, what they do during the day. When you practice-wise, I'll give you some options through here. Unilateral and central PAs, there's a video attached to that part in the manual, and unilateral PAs in flexion extension. Again, if it's something you don't do in your practice, you can add in other components of it. You could do some sideline A to P glides just to see the mobility, etc., mobility testing. Good thing is teach them a general separation technique. I like the one axial separation and flexion. Put a video in. You could watch that video. The key is just to open up that upper segment. And then soft tissue-wise, again, some options are, we teach them, I like to cover the mountains and dig out the valleys. So cover the mountains, again, meaning that if an area is more flexed and is rounded, like a kyphosis area, you push the tissue from lateral to medial over it, covering the mountains to facilitate extension. And if you have a valley, which is an extended segment, again, you pull tissue from medial to lateral to facilitate extension. You could show them muscle testing. Again, if you have time with it, muscle testing, abdominal testing, watch the videos. Multifidi activation in prone, we did that last as an example of how to find it. Patient is prone, they lift up the right arm, you should feel the left one activate, etc. And then you're going to teach them a little bit about different options. So mobility first. You could talk about just any joint techniques that you wanted to. Here's examples you could use to get flexion, some soft tissue techniques. Then we start talking about some type of where do we start stability program. The key I want you to get out of this part, some of the recent studies talked about the use of words activation, acquisition, and assimilation. So activation is finding that muscle, isometrics. Next one, acquisition is actually be able to activate the right muscles and then do an active motion on top of it, which is the exercise itself. Assimilation is a functional technique. Sit to stand, step up, step down, etc. And just go over in that component of it. You can go over each component and say progression of it. So teach them the idea of lying, and the next would be quadruped, half kneeling, kneeling. And that's basically what we're going to do during those sessions. Just going to discuss those parts with them, kind of give them some ideas, ask questions. If there's some techniques you like specific that goes appropriate with the case study, feel free to add that.